Dr. Kaisur Rabi, pediatric orthopedic surgeon, welcoming you all to attend CME on management of osteoporosis, powered by vitamin D, Vita D3. Today we have Renata as our scientific partner and RAS TV as our media partner. Today on the chair we have Professor Dr. Afomo Ruhul Haq, MP, ex-health minister and teacher to many of us. In the panel of experts, we have orthopedic and spine surgeon, Professor Khandokar Abdul Awal Rizvi, ex-president Bangladesh Spine Society, ex-president Bangladesh Orthopedic Society, and director NITOR. We also have Professor Ashomo Jahangir Chaudhuri Tito, ex-principal Faridpur Medical College, and assistant professor Dr. Anadi Ranjan Mondol, Faridpur Medical College. In the speaker session, in the speaker part, we have two tremendously good speaker. First speech will be delivered by young and booming orthopedic and trauma surgeon, Dr. Shubha Prasad Das. And the second and keynote speaker will be Professor Dr. Professor Dr. Syed Shahidul Islam, sir. He was ex-GS Bangladesh Orthopedic Society and ex-academic director of NITOR. So I would like to seek permission from our chairperson to start the program. If you please, sir.
Please go ahead. Thank you very much. Thank you.
Thank you, sir. Thank you for your kind permission. Now I would request Dr. Shubho to start his presentation, but before starting his presentation, I would request all our viewers to use the comment section. If you have any question regarding management of the osteoporosis, please put your questions in the comment section and we'll come back to you after finishing the speech of Dr. Shubha Prasad Das and Professor Dr. Syed Shahidul Islam, sir. Thank you all.
I have a little problem. I am on Indian television in 10 minutes, direct from here. So can I say something now and then come back? I don't think I...
Sure, sir. Sure, sir.
So the presentation must be a few minutes, 10, 15 minutes. Probably I'll miss some of it. So I wish you all the best. First of all, I would like to thank the organizers. The osteoporosis is a very important issue on orthopedic surgeons, but not only orthopedic surgeons, but also physicians and many other people. We have not yet been able to conquer osteoporosis, although we know a lot of things that have come forward. Anyway, I would like to thank the organizers for such a wonderful meeting. Actually, this meeting with the Indian television has just come 20 minutes ago, so I could not defer it, and this is on live. I have to go live now. So I'll miss some of the presentation, but hopefully I'll come back and talk to and catch up with you. So you'll have to excuse me and for this unfortunate event, but I wish you all the success. I'm sure my meeting with them cannot be more than 10-15 minutes since it will be a live TV. So I wish you all the luck, and then please excuse me for some time. I'll come back as soon as I finish in there.
Thank you, sir, for your blessing. And now I'd like Dr. Shubha Prasad Das to start his presentation. Please, Dr. Shubha Prasad Das, unmute yourself and share your screen, please.
Thank you. Dr. Kaisur Rabi, can you see my presentation?
Yeah, you are quite good. Please start.
Okay.
Can you go for the slideshow option?
Yeah.
That means the present. Yeah. Please. Thank you.
Thank you, Dr. Rabi. Welcome you all on the live CME on osteoporosis organized by RAS TV. Thank you to the chairperson of this webinar, Professor Afomo Ruhul Haq, MP, sir, Honorable ex-Health Minister, and Professor Khandokar Abdul Awal Rizvi, sir, our keynote speaker, Professor Dr. Syed Shahidul Islam, sir, our panel of experts, Dr. Ashomo Jahangir Chaudhuri Tito, sir, and Dr. Anadi Mondal sir for giving me the opportunity of presenting me on these topics. I am Dr. Shubho Prasad, orthopedic and trauma specialist from NITO. In this pandemic situation where a contagious disease around us, we have to stay our home, and physical activity can lead to osteoporosis. So today I'd like to share my talk on basics and pathophysiology of osteoporosis. So at first, at the beginning, what is osteoporosis? It is literally, osteo refers to bone and porosis means the pores. So osteoporosis means when there is a higher breakdown of bone in comparison of formation of new bone, which result in a porous bone. So osteoporosis is a condition where bone mineral density decreases and that leads to fragility of bone, which eventually leads to fracture. Prior to the widespread application of the bone mineral densitometry, osteoporosis were rarely diagnosed, and that time only there are suspicion where there is symptomatic vertebral fracture and osteopenia seen in radiology. For too long time, hip fracture at the end point of this metabolic disease where either thought it is the consequence of aging or ignored in respect of treatment. But after wide use of bone densitometry, WHO set a working definition for osteoporosis. What is that? The World Health Organization has defined osteoporosis as the T-score below -2.5 and defined osteopenia as a T-score between -1.0 and -2.5, whereas the normal bone mass as above -1.0. So we have to understand what is the T-score and what is the Z-score. When your score compares your result to a healthy young adult at age of 20 to 35, that is T-score. And when you compare your result as a person of the same age and same gender as yourself, that is Z-score. So after setting the working definition, it is easy to identify who are susceptible to osteoporosis and who are susceptible to osteoporotic fractures. So how we classify osteoporosis? Osteoporosis may be classified in two broad headings. First one is primary osteoporosis and second one is secondary osteoporosis. The another name of primary osteoporosis is involutional osteoporosis. And our main topics is today focused on the primary osteoporosis. The primary osteoporosis is again divided into two types. Type 1 is postmenopausal osteoporosis and type 2 is senile osteoporosis. And there are some secondary cause of osteoporosis like some endocrine disorders, some drug-induced disorders, some malignancy, nutritional disorders, and some idiopathic cause, and this very important cause, and which is prolonged bed rest and sedentary people who is less workforce, then that is another cause of osteoporosis. So when we go to the basic structures of a bone, there is an external layer that is hard layer that is called cortical bone, and there is a soft internal layer named spongy bone or trabecular bone. The trabecular bone is composed of trabeculae, and the trabeculae are the structural beam that forms the framework of a spongy bone, and the cortical bone are made like many pipe-like units that is called osteon, and which run through the bone, and in the center of the osteon there are some hollow spaces that is called Haversian canal. That Haversian canal contains the blood supply and innervation of the bone. Around the Haversian canal, there are some concentric lamella, which a bit like a tree. The lamella have an organic part, which is most like collagen, and inorganic part, which are hydroxyapatite crystal, mostly calcium phosphate. In between two lamella, there are some space which are called lacuna, which contains bone cell and called osteocyte. At the first glance, bone may appear an inert and unchanging substance, but bone is a very dynamic tissue. And this dynamism is maintained by bone remodeling process. Bone remodeling process is made up of two basic things. One is bone resorption and another is bone formation. So what is bone resorption? Bone resorption, in which a specialized cell named osteoclast break down the bone, and another type of cell named osteoblast, which is responsible for the bone formation. And this bone remodeling is highly dependent on serum calcium level. Serum calcium level, which in turns are kept in the normal range by a balance between parathyroid hormone, calcitonin, and vitamin D. Parathyroid hormone is produced by the parathyroid gland in response to low serum calcium level that increase bone resorption and release in the blood circulation. On the other hand, calcitonin is produced by the thyroid gland in response to high serum calcium. So it opposes the action of the parathyroid hormone, therefore promoting bone formation and decreasing bone resorption. And finally, vitamin D. Vitamin D promotes calcium absorption in the gut and thus increase the serum calcium, promoting bone formation and decreasing the bone resorption. So the result between these homeostasis caused a specific thing which is very important in the topic of osteoporosis, that is peak bone mass. So when we deal with the peak bone mass, we have to understand what is the peak bone mass. Bone mass accretion starts from the childhood and continues in the adulthood, usually occurs earlier in the female than male. Peak bone mass can be achieved in the mid-20s for the spine and hip, while other bones such as radius reach a peak at the age of 40 years. After that, bone mass normally declines. There are some factors which are determine the peak bone mass. At first one is genetic factor. For example, people of African descent tend to have greater bone loss, bone mass, and nutrition. Second one is nutrition. Adequate vitamin D intake can increase bone mass. And a very important factor which is very much necessary in this pandemic situation, that is physical activity. And physical activity increases the bone mass. And finally, some hormones like estrogen and androgen that inhibits bone resorption. So now, when osteoclasts break down bone faster, then the osteoblast can rebuild it. It results in the lowering of the bone mass eventually, which leads to osteoporosis. If we look to the slide, microscopic section, cross section of a osteoporotic bone, it will show normal cell with normal mineralization. But which is differentiated from the osteomalacia, where there is lack of mineralization. So abnormal microscopic finding of osteoporosis is fewer trabeculae in the spongy bone, thinning of the cortical bone, as well as widening of the Haversian canal. The bone changes increasing the risk of fracture. These fractures are known as fragility fracture or pathologic fracture. Some bones like shoulder bone, vertebra, and ribs consist of mainly spongy bone, so they are at the great risk of fragility fracture. So now I am discussing about the main cause of primary osteoporosis, that is postmenopausal osteoporosis. Before going to the postmenopausal osteoporosis, we have to understand what is the role of estrogen in the bone physiology. There is a protein named RANK ligand promotes the activation, differentiation, and survival of the osteoclast via interaction with its receptor named RANK. When a rank ligand activates a osteoclast, it resorbs the bone. So what is the role of estrogen on this matter? Estrogen downregulates the rank ligand signaling, which decreases the rank and subsequent decrease of the bone-mediated bone resorption. So estrogen also have been shown to stimulate the expression of osteoprotegerine, a hormone which inhibit a protein which inhibit the activity of the rank ligand by preventing it interrupting with its receptor. So in menopause, when the estrogen level decreases, rank ligand production is increases, so increase of the bone resorption. Increased bone resorption lead to accelerated loss of bone mineral density, which can result in the most severe condition called postmenopausal osteoporosis. And another variation of osteoporosis is senile osteoporosis. Senile osteoporosis is the osteoporosis that is believed that osteoblasts are gradually lose the ability to form bone with the process of aging, but osteoclast doing to keep it work. So bone resorption usually overtakes the bone formation, and it occurs around the 7 to 8 decade, and it is called senile osteoporosis. So when we summarize the risk factors of osteoporosis are, we can memorize it by a mnemonic name access, that is alcohol overuse, some drug like corticosteroid, heparin and levothyroxine, low calcium level, low estrogen level, smoking, and sedentary lifestyle cause the risk factor of the osteoporosis. There is a study on primary osteoporosis that suggests that the achievement of peak bone mass is the most important to the bone health and plays a vital role in preventing osteoporosis and subsequent fracture in the later years. So not vitamin D, not anything. It is the peak bone mass which is very much important for the prevention of the osteoporosis. And they suggest that hip fracture could be reduced by 30% with an increase in the peak bone mass 10%. I want to conclude with a poster published by World Osteoporosis Foundation. They advise by taking regular action through your regular exercise, a bone healthy diet, and consulting your doctor about the risk of osteoporosis, and avoiding smoking and alcohol can protect your future by not to fracture your bone by osteoporosis. That's all from my point about the basic pathophysiology of the osteoporosis. Thank you, sir.
Thank you, Dr. Shubha, for your nice delivery of your presentation. And now I would like to introduce you to our new guest, Professor Dr. Mohammad Anwarul Islam, sir. He is the General Secretary of Bangladesh Spine Society. He has just connected with us. And to our learned audience, please put your questions. You can address those questions with speaker or with our panel of experts if you like to. Just put your questions in the comment section so that I can collect those questions and transfer those questions to our speaker. Now I'd like to request Professor Shahidul Islam sir to start his presentation. Thank you very much, sir. Sir, you need to unmute yourself, I think. Professor Shahidul Islam sir, sir, you need to unmute yourself. Sir, you need to unmute yourself.
Okay.
Okay, thank you, sir. Yeah, we can hear you now.
Can you see my presentation?
Yeah, we are seeing your presentation. It's nice. Okay, you can start, sir.
So thank you, Dr. Kaysar Rabbi. the moderator. And I would like to express my thanks and gratitude to our honorable chairperson of the session, Professor F.M. Ruhul Haq, MP, who is the ex-successful Health Minister of Bangladesh. And our panelist, Professor Dr. Khandakar Abdul Awal Rizvi, the President of Bangladesh Spine Society and ex-President of Bangladesh Orthopedic Society, as well as the ex-Director of NITO. Professor Ashrama A.S.M. Jahangir Chaudhary Tito is the ex-Principal of Faridpur Medical College, and Dr. Anadi Ranjan Mondol is also the Assistant Professor of Faridpur Medical College. And my previous speaker nicely and elaborately has described the pathophysiology, and he has given the definitions also. I would continue with with him, and there may be some overlapping. You can, this is also he defined already what is osteoporosis, and according to World Health Organization, he said that also referred to as T-score of minus 2.5 is osteoporosis. I have to find out this. I'm very interested about the osteopenia, when this T-score is -1 to -2.5. This is osteopenia. We are usually say osteopenia. I want to like to say this is less bone mass. This is bone mass is decreased because he is or she is going to osteoporosis. We have to check this portion also. And you see regarding the epidemiology, especially in Bangladesh and India, actually the prevalence of osteoporosis remain unknown because of the asymptomatic nature of this disease. In India, it has been postulated that 35% of the postmenopausal women are at the risk of developing osteoporosis, and osteoporotic bone fracture commonly occurs. Commonly occurs at the vertebra, hip, and wrist. All of you know. On an average, a postmenopausal woman has 40% to 50% chance of developing fracture, including 15% chance of hip fracture in her lifetime. Very interesting. More than 10% of the hip fracture victims die within 1 year from various complications. And nearly 50% of the survivors are incapacitated, some of them permanently. So this is very alarming situation. Regarding the global concern, all of you know 1 in 3 women and 1 in 5 women is suffering from osteoporosis who are above 50 years of age. And 15 to 30% men and 30 to 50% women suffers fracture related to osteoporosis in their lifetime. So already Shubha Prasad has said, we attain the peak bone mass. And this is the main period. I want to say first time. Sometimes we people are incoming for our future. When there will be no job, we will be idle. We have to spend money for that time. I want to say that you deposit your bone, attain the high peak bone mass for future. So those you should have not developed osteoporosis, or you should not develop any fragility fracture. So there's a consolidation period, he said, and this is a sudden fall after 45 years, when menopause starts. And you can say there's a sudden fall and it crosses the fracture threshold. This is very important, and therefore the fragility fractures occurs. He has already said what are the risk factors like Caucasian race, advanced age, female sex, and premature menopause, that is before 45 years, and prolonged time of about more than 1 year without a menstrual period, short or undersized person, and operative removal of the ovary is one of the important causes, especially in our country. If you go to periphery, you will find many ladies have no ovary. So these factors are modifiable, non-modifiable. We cannot change, but there is modifiable factors. That cigarette smoking, excessive alcohol intake, inactivity, like this pandemic period, we are all of inactive remaining within our home. Low body weight is very important. Patient can develop osteoporosis, and poor general health and prolonged immobilization and long-term taking of steroid. So how to assess the osteoporosis? We usually call, the physician usually called osteoporosis as a silent killer. because it does not produce any symptoms. We can see only the tip of the iceberg, but maximum portion remain obscured. We cannot see, and patient cannot present and have no history of any symptom. For these reasons, most of the osteoporotic patients are usually not identified in our society. We have to look for the risk factors already told, and the family history. There is a genetic predisposition, and we have to take the medical history, especially the low back pain, when there is a height loss, or there is a change of posture, or if there is any fracture, especially fragility fracture. Shubham Prasad already said fracture neck fiber, vertebral fracture, wrist fractures, proximal humerus fracture, etc. And in this case, we have to examine the patients and we should go for some laboratory investigations. But already my previous speaker told you that BMD testing is the gold standard for the diagnosis. So we have to keep in mind some differential diagnosis. These are the secondary cause of osteoporosis, already hyperparathyroidism like this, but also Paget's disease, osteomalacia, osteogenesis imperfecta, multiple myeloma, secondary tumors, sometimes confused with osteoporosis. We have to keep in mind. For these reasons, we have to go for some routine investigations, especially some blood count, sedimentation rate, C-reactive protein, serum calcium, albumin, creatinine, phosphate, alkaline phosphatase, and liver transaminase for the secondary cause of osteoporosis, and thyroid function test, and lateral radiograph of the lumbar and thoracic spine. And the standard is the bone densitometry. We have to go for other investigations also, like serum protein electrophoresis, urinary Benzon's protein, serum 25-hydroxy vitamin D. I will come later on. Plasma parathyroid function, serum testosterone, sex hormone binding globulin, follicle stimulating hormone, luteinizing hormone, serum prolactin, and 24-hour urinary free cortisol or overnight dexamethasone suppression test, and markers of bone turnover and urinary calcium excretion, and other many investigations we have to go for identifying secondary osteoporosis and for differential diagnosis. So X-ray previously, or my previous experiences, this was the golden standard. During my studentship, I found that X-ray, with the X-ray we diagnose the case of osteoporosis. But osteoporosis produces increased radiolucence of the vertebral body. Approximately 30 to 80% of the bone tissue must be lost before recognizable abnormality can be detected on spinal radiograph. But it depends on the quality of your machine, depends on the quality of the technician, depends on the size of the person. If the size is obese, we cannot detect the bone quality. So these are the fractures already my previous said. Previously, we used this Singh index for diagnosis of osteoporosis. Nowadays, it is not easily used. Just for recapitulation, I put this figure in front of you. There are some screening tests available in our country, and many people did this screening test, but there is a problem, like quantitative ultrasound and peripheral quantitative computed tomography. This is also called peripheral test, but no one technique serves all the functions of skeletal assessment, including diagnosis, prognosis, and monitoring of the treatment. Only BMD can do everything. So we need to BMD. This is dual energy X-ray absorptiometry for BMD. This is the machine. Remember that when we will go for the follow-up of the patient, you should have BMD from the same machine, by the same technician, and by the report by the same physician. So you can compare them. So the International Society for Clinical Densometry said that femoral neck is the predictive value for the fracture risk, and spine for assessing the response of the treatment. Everybody, when we advise for BMD, we get this type of picture, and we can calculate from here that the patient develop osteoporosis or osteopenia or normal. Who should go for testing of BMD? This is a very important question. If you cannot send everybody to this for this test. The candidates are older than age 65 years, regardless of the risk factors. But in United States of America, they told 65 years in case of female and 70 years in case of male. But postmenopausal women and have at least one risk factors for osteoporosis, including having a fracture of the bone, having vertebral abnormality like kyphosis or low back pain already said, and use medication like prednisolone that can cause osteoporosis. Type 1 diabetic patient with liver disease, kidney disease, thyroid disease, or a family history of osteoporosis above 50 years. It is done in Natur, Dhaka Medical College and KR Medical College Hospital between January 2018 and December 2018. Number of the patient was total 200, male was 91 and female was 109. And we found that rate of osteoporosis, you can see here, the 35% in our study, 30% people over 50 years of age having no abnormality, we found osteoporosis. And 41% osteopenia. So total 76% patient has osteoporosis and osteopenia. I think it is alarming for our country. So in our study, 1 in 2.2 female and 1 in 4 male suffers from osteoporosis. But in international study, it is 1 in 5 male and 1 in 3 female, already told. We did the study also that what is the status of vitamin D, that there is a lot of talk about the relationship of vitamin D and calcium with the development of osteoporosis. You can see here that there is a deficiency of osteoporosis, a deficiency of vitamin D in 63%. 63% patient, and insufficiency 23%. At total, 87.5% patients below the level 30 nanogram, below the level, and 63% deficiency of vitamin D. But we find no association found between the osteoporosis and serum vitamin D. You see here, the normal patient 36% develop osteoporosis, in insufficiency 32%, and deficiency 37%. So there is no statistical difference between the deficiency of vitamin D and normal vitamin D level. So there is no association like this. In our study, about 200 population, we found only 6% patient, only 6% person have low calcium and one is high calcium. So only 7% patient is abnormal calcium level. And we found no association between osteoporosis and calcium deficiency or normal. So this is interesting to me. So rate of osteoporosis, this is interesting that 52.4% patient develop osteoporosis who belongs to the age of more than 70 years. And less than 60 years, 24.5%. So this is a good news. Now, how we'll go for managing the osteoporosis? There is a National Osteoporosis Guideline Group developed this management protocol in 2017 and updated in 2019. You will find it. These are the group or other organizations that develop this, and you can find this on the website. And they say we will go for BMD, assessment of fracture risk first. Because why we are afraid of osteoporosis? Because there are chance of fragility fractures. In case of postmenopausal woman and in case of man over 50 years, we should go for WHO fracture risk assessment tool. But unfortunately, for our country, there is no such tool available in the website. This is for some developed countries. We can put all this data here and we can find the assessment of fracture rates for 10 years for hip fracture and other bone fracture by using this one. This is not available in our country. So vertebral fracture can be considered, assessed with the patient of postmenopausal woman, men over 50 years, If there is a more than 4 centimeter height loss, is the patient has kyphosis and having oral steroid, and BMD-T score is less or minus 2.5 standard deviation. So how we prevent or treat osteoporosis? Very important is non-pharmacological treatment, very important. We should consider about diet, physical activity, and which we can avoid easily, especially in our country. Please avoid smoking. Many of our doctors is habituated to smoking. Avoid soft drink and caffeine. There is controversy about the caffeine. If you take caffeine, you have to take vitamin D side by side and calcium. So avoid alcohol. Fortunately, we are not habituated, our nation is not habituated to the alcohol. And you have to go for sun exposure and avoid steroid, anticoagulant, and antiepileptic drug if possible. If not possible, we have to go for another treatment protocol. And please avoid, try to prevent fall of the senior people. What is about diet? First of all, we should take a balanced diet, which must contain sufficient amount of protein, 1.2 gram per kg per day. Especially these men and women over 50 years of age. Calcium, 1200 milligram per day, not more than 200 milligram per day because there may be some side effects. And vitamin D, 800 international per day for this. Not for younger group. This dose will be less. And we should take this type of diets which are rich in vitamin D and calcium. If we need it, if we go for investigation of vitamin A, then we can supplement. And if we can get from this amount of vitamin and calcium, we don't need to supplement them. What is the role of exercise? And what type of exercise we should do? Walking, running, jogging, jumping, and jumping rope. Best one is running, jumping, and jumping rope, jogging. But is it people? It may not be possible. So walking, at least walking. And time frame should be 30 minutes daily. Somebody says 5 days in a week. If possible, 30 minutes daily. This is also for prevention of osteoporosis. What I am telling now, the diet and this exercise, this is also for the prevention of osteoporosis. What does weight-bearing exercise do? It improves bone mass, directly stimulates osteoblast for new bone formation. Muscle strengthening exercise, especially stressing exercise or carrying weight in hands or resistance exercise. The muscle attaches with the bone is stimulated and the new bone formation occurs. And it also improves the balance so that the person cannot fall easily. Don't stop your exercise. If you stop exercise, suddenly bone mineral density will fall. I have to introduce one term probably new to somebody, the sarcopenia, and osteoporosis run hand to hand. Sarcopenia means is related lots of muscle mass, strength, and functionality. So if it happens like that, it will be a problem and patient must develop osteoporosis. Try to prevent the fall of the aged persons. How will you do that? Exercise like balance training exercise, lower limb strengthening exercise, correction of sensory impairment like correction of low vision and hearing impairment, reduce environmental hazard, appropriate reduction of medications which can provoke to fall the patients, appropriate education of the patient, and you can give some measurement in your home. Use handrail on stairs and also at the bathroom where there's aged person. Keep floor clutter free. Keep the floor clean but not slippery. Use rubber mat in the bathroom or in front of the bathroom or where there is a tub. Use rubber mat. Use a 100-watt bulb in all rooms so that these aged people can see and can work. So who should be considered for the treatment by pharmacological agent? Postmenopausal women and men aged 50 years older presenting with following should be considered. Number one, a hip or vertebral fracture. How I can deteriorate? Clinically apparent or we found by imaging. T-score minus standard deviation minus 2.5 or more than minus 2.5 at the femoral neck, total hip or lumbar spine. Low bone mass, that's a T-score minus 1 and minus 2.5 standard deviation at the femoral neck or lumbar spine. A 10-year probability of the hip fracture is about 3 or more %, or a 10-year probability of major post-osteoporosis related fracture is 20% or more. It can be assessed by using FRAX, but which are not available in our country. What are the pharmacological agents available in our country and we can use? Bisphosphonate, one of the gold standard treatment, and denosumab, hormone replacement therapy, estrogen-like mediators like selective estrogen receptor modulators, SAMs like raloxifene, tamoxifen, and this is I'm going later on, parathyroid hormone analog like teriparatide, and this is the red mark I guess, this abaloparatide. It is yet not approved by FDA in case of high risk patients, and calcitonin. These are the drugs we use. Bisphosphonate is widely used in our country, also in another part of the country, in another country also. These are the analogs of pyrophosphate and bismuth 2 pyrophosphate attached together and causes apoptosis of the osteoclast by disrupting the cytoskeleton. It occupies the site of whose site for the osteoclast and reduce the osteoclastic activity as an process of the osteoclast, and thereby inhibit. What are the bisphosphonate? These are the third generation bisphosphonate is not used nowadays. These are the second generation, alendronate, ibandronate. These are the second generation bisphosphonate. And residronate and zoledronic acid are the third generation bisphosphonate. You know the dose of alendronate 10 milligram daily tablet or 70 milligram weekly for the treatment. And ibandronate 150 milligram monthly tablet. And residronate 150 milligram monthly tablet or 35 milligram weekly tablet. And zoledronic acid, basically personally I prefer zoledronic acid because of the dose convenient, and we can give follow-up only after 3 years. And if we give oral bisphosphonate, we have to give for 5 years, but zoledronic acid for 3 years. What are the side effects? Side effects for all oral bisphosphonate are gastrointestinal problems such as difficulty in swallowing and esophagitis, gastritis. For this reason, we advise them to take the drug in the empty stomach in the morning, or at least 1 hour before the intake of food, and remain standing or sitting, not to lie. All bisphosphonate are contraindicated in patients with estimated GFR below 30 to 35 ml per minute. You should remember in that. Osteonecrosis is one of the complication of bisphosphonate and side effect of bisphosphonate. Another is low trauma atypical femur fracture, usually the proximal part of femur. This is the common side effects. And teriparatide. Teriparatide is one of the well-known drugs used in different countries, especially in America. It is the parathyroid analog and approved for the treatment of osteoporosis in the postmenopausal women and men at high risk fracture. It is also for the treatment of the patients who cannot avoid glucocorticoid therapy, and we usually prefer this for this drug. Dose is 20 microgram daily in subcutaneous injections, but it should not be continued more than 2 years, 18 to 24 months. If you stop it, we will go for anti-resorptive drugs like bisphosphonate. There are some already I have said, selective estrogen receptor modulator drugs. So this is the raloxifene, 60 milligram per day, but it has some side effect like deep vein thrombosis and hot flashes of the leg and leg cramps. Calcitonin, you can use calcitonin, but there is some complication of calcitonin. You know, calcitonin is produced by the thyroid gland, and the dose is 200 international unit delivered as a single daily nasal spray, but it can cause rhinitis, epistaxis, allergic reactions, and even cancer. I don't like to this calcitonin. So this is one of the beautiful drug. Already my previous speaker says Rankel inhibitors, denosumab. Somebody like donimab, but it should be denosumab. It occupies these are the denosumab. You can see the figure. These are the denosumab. Occupies this Rankel. Already he said this rank ligand and occupied, so it cannot this rank ligand. This rank ligand is produced this by osteoblast, and is they occupied this rank ligand, and it cannot bind with the osteoblast precursor, and they cannot fuse with each other and cannot form. Ultimately, they are not able to destroy the bone. This is the new update. Came in 2020, romosozumab, but still the FDA deliberation has had some cardiovascular problem and some also cardiovascular incidents may occur. In this case, it is not widely used. The dose 210 milligram monthly subcutaneous injections for 12 months. The pharmacological intervention treatment should be reviewed 3 years after zoledronate acid, already I've said, and 5 years after oral bisphosphonate, and continuous phosphonate therapy is needed more than 75 years if there is a hip or vertebral fracture or patient taking a steroid. The osteoporosis for men, alendronate or residronate is the drug of choice, but you can use the intravenous bisphosphonate and denosumab also. Dear friends, this is our beautiful memory. This is the first National Institute of Traumatology and Orthopedic Rehabilitation. Our chairperson, he was the president of Bangladesh Orthopedic Society as well as the director of NITOD. This building was there. And I must give thanks to the Honorable Prime Minister Sheikh Hasina that after our request, our then director, one of these panelists, Professor Khandukar Abdullah Rizvi, followed by Professor Iqbal Kabi, and followed by current director, Professor Abdul Ghani Mullah. They tried the level base to develop a new building here and addition of extra 500 bed and now the totally 1,000 bed hospital. So after demolition, when we decided to break this, we seen that after some trauma by bulldozer, it breaks like that. This is called osteoporosis. And you can build it, rebuild it. This is like that. So we are very grateful to them, the Honorable Prime Minister, then the ex-health minister, and the directors named and said, this is our new proud of NITOR, addition of extra 500 bedded hospital, total 1,000 bedded, and the largest hospital in the orthopedic hospital in the world. Love your bone, protect your future. Thank you for your patient sharing, and thank you for all the presenters and panelists. If you have any question and comments, you are most welcome. Can I stop
Thank
my
you,
sharing?
sir.
Okay.
Yeah, thank you, sir, for your nice presentation. Now, I would like to request all our panelists to unmute yourself if you want to. And if there is any question for you, I have a few questions for our panelists and for our speakers. Can I go for the question and answer session now? Okay, so the first question is to my Abdul Awal Rizvi sir. The question is role of vitamin D3 in management of osteoporosis. Sir, you need to unmute your mic. Then, sir, role of vitamin D3 in management of osteoporosis. Sir, can you unmute yourself, sir, please?
So click on the unmute portion. Probably it is in the above the screen. Probably it is above the screen.
Okay.
Who is the administrator? Please unmute the mic of Professor Khandekar Abdullah.
So if you are operating through your laptop, you can click the space bar. It will unmute yourself. Just space bar.
মাইকের চিহ্ন যেখানে আছে ল্যাপটপে নিচের দিকে বা উপরের দিকে, নিচের দিকে আছে আমারটায়।
একদম নিচের দিকে আছে মিউট বাটন।
নিচের দিকে আছে স্যার। স্যার নিচের দিকে একদম লেফটে।
নিচের দিকে লেফটে।
আপনার লেফটে। এখানে ক্লিক করেন স্যার। যেমন আমি এই যে ক্লিক করলাম আমি আনমিউট হয়ে যাব।
Okay, sorry, it is giving some trouble. Okay, first of all, thank you very much for nice presentation, and Professor Uluk sir, you have come again. Thank you for joining us again. So Dr. Rabbi asked me what is the role of vitamin D in the prevention of
osteoporosis.
We know that vitamin D is required for the utilization of the calcium. Calcium is required for mineralization. You know, in osteoporosis, the main problem is in protein, in the matrix. But we know that for the mineralization, we need both calcium and vitamin D. Normally, there are enough calcium in the body because calcium is readily available in foods, in vegetables, in milk, in cheese, in yogurt, so which we commonly consume. But even having sources of vitamin calcium and vitamin D should be readily available in our country because it's naturally available when we are exposed to sunlight. But unfortunately, the present studies shown, Dr. Shoid has also shown that the deficiency of vitamin D is very rampant. I do not know why in the past when there was no facilities for detecting the level of the vitamin D in our country, we didn't know that. But when we have facilities, when we test for vitamin D, we find there are many people actually having less than normal. Normally it's about 20 to 30 nanogram or like that. But we sometimes find less than 20, even less than 10 in some cases. So this is a serious problem. So without vitamin D, you cannot utilize your calcium. For the absorption, utilization is required. So that is the most important in the metabolism of this calcium. Vitamin D is essential component. So we need to have our vitamin D enough. What is enough? There are debates. So is it 30 nanogram or it is more than that? But normally it's said that it should be not less than 30. It is better to be in between 50 to 60 nanogram per deciliter. So vitamin D, how can you get it? Unless you have some serious illness, vitamin should be readily available, and also vitamin D is available in vegetable and also in animal products. So one should be very careful about his level of vitamin D. Thank you. Is that
thank
okay
you very
for
much.
you?
Yes, sir. Thank you very much for your nice explanation regarding the role of vitamin D3 in management of OP. And now the next question is to Professor Dr. Mohammad Anwar, sir. Is osteoporosis in the spine is painful? And the second question that comes with it is, can osteoporosis in a spine be reversed? That means if we go for calcium or other substitute measures, whether we can reverse that osteoporosis for spine or not. Thank you, sir. Sir, sorry, sir, we can't hear you.
Anwar sir, please.
Sir, Anwar sir, sorry to say, but we can't hear you.
Okay.
Maybe the headphone is faulty, sir. Sir, headphone খুলে কথা বললে বোধহয় শোনা যেতে পারে।
ডক্টর আনোয়ার হেডফোন খুলে ফেলেন, খুলে ফেলেন।
Okay.
মোবাইল থেকে খুলে ফেলেন।
Now
Hello,
you are
can you
audible, sir.
hear?
Yes, sir. Thank you, sir.
At first, thanks to our Professor Ruhul Haq sir, and who was the successful ex-Prime Minister and who chaired this session, and my ex-Health Minister who chaired this session, and my respected teacher, Professor Kondokar Abdullah Rizvi sir, President Bangladesh Spine Society, Professor Soyed Shohid sir, Professor Titu sir, and other participants also. It's a very nice question that in case of osteoporosis in the lumbar spine or cervical spine even, whether there may be the symptomatic or asymptomatic. Definitely most of the patient was asymptomatic, but some patient presented to us with the severe back pain even. And after investigation that there is no neurological involvement, but pain persisting day by day, even years together. In that situation, when you go for BMD test, that the patient's test was less than minus 2.5. In that situation, we can diagnose that this is a case of osteoporosis of the lumbar spine. And after doing some x-rays, say pelvis, there is osteopenia in the neck of the femur as well as the upper femur, even iliac bone as well. After the age of 70 years or even 65 years patient shows that there is a osteopenia over there. In that situation, it is diagnosed as osteoporosis, and what our Professor Soyed Shohid sir says, we usually treated by the zoledronic acid. That is injection zoledronate, 5 milligram in 100 ml of dissolved in 100 ml. In this injection, we give yearly, and for the 3 years, after then we check again BMD. If it is normal, it discontinue. If it is not normal, then it can be continue for even 5 years. This is the actual parameters. And in case of osteoporotic vertebral fracture, this is a different entity. Definitely, it has a sometimes needs to be the surgical intervention. Very fewer percentage of cases need to be surgical intervention, where there is compressing the neural elements or any neural symptoms due to the compression fracture of the vertebra. In that situation, we go for surgery. Different modalities of surgery is there. Even in our country also, we are doing different modalities, say minor procedure, kyphoplasty, vertebroplasty, and major procedure, the resection of the vertebra and stabilization by the pedicle screw and rod, etc., etc. So definitely, osteoporosis in the spine have got some symptoms, and when it is symptomatic, it should be treated. And when there is a complication of osteoporosis of the spine, like fracture, definitely it should be treated earlier. Thank you very much for patient sharing, everybody.
Oh, thank you very much for your nice explanation. The next question is to my professor, Syed Shahidul Islam sir. The question is, in a 45 years old postmenopausal lady, which one should we prescribe? Ivandronic acid, zoledronic acid, or we should go for hormone analysis to find out whether there is any other problem like estrogen deficiency or like that, something.
You said, thank you. He said that the 45 years post-menopausal woman just started post-menopause. If she has no pathology or other secondary cause of osteoporosis, or he is not a candidate to think about for the osteoporosis, and he is not advised for investigation of BMPs. I said it. After 65 years, without any complications or osteoporotic fractures. So we are not thinking that this lady having osteoporosis. So what was the question?
So the question was, which one should we prescribe? Whether we will go for ivandronic acid or zoledronic acid?
No ivandronic acid, no zoledronic acid. She is not a candidate for this medicine. I will prescribe him what I have told the intake regarding diet, regarding vitamin D, regarding calcium, and physical exercise. Physical exercise is the very important, especially the weight-bearing exercise. She must do it, and already I've said physical exercise in weight-bearing exercise, the osteoblasts get stimulated to for newborn formation. Why you will not go for that? She don't need any bisphosphonate.
Maybe this question was due to most of the we have seen many patients like they are overweight, so and they are not too much prone for exercise or going for physical activities that much. Maybe that's why.
Dr. Kausar Rabbi, overweight patient usually does not develop osteoporosis. It is the case where the osteoporosis usually not occurs. Overweight is better for having no osteoporosis. So overweight, he has to reduce the weight by doing exercise. No medication is needed. Be careful, clear about this. In 45 years, no bisphosphonate is needed. Either it is patient having rheumatoid arthritis, patient, I told you, patient having diabetes or in celiac disease or kidney problem, and patient T-score is minus 2.5 standard deviation, then or happen any fragility fracture, then we prescribe for bisphosphonate.
Thank you very much. So the next question is for Professor Khandekar Abdul Awal Rizvi sir. Clinically, how to differentiate osteoporosis and osteomalacia? If there is any way we can differentiate between osteomalacia and osteoporosis by clinically.
Clinically, actually, osteoporosis itself is a silent disease, and from the observation of the patients or examinations, it is hardly to detect any point. There's hardly any point to detect osteoporosis or osteomalacia. In osteomalacia, sometimes patients may have aches and pains. That's all. But this is not very common as well. But often patients do present with aches and pains. Otherwise, there is nothing to. But in osteoporosis, if it is established, then it can be detected from the observation. As for example, if we observe the patient, we know this because of the osteoporosis, height of the patients may reduce. There may have kyphosis, which may be pronounced. Okay, and often patients do have some feelings of weakness of the muscles. But apart from these investigations, it is very difficult to classify whether this is osteoporosis or osteomalacia. Otherwise, I do not feel that there is a significant way of differentiating osteoporosis and osteomalacia from the observations or just from clinical examinations. But by investigation, definitely you can get a clue whether this is osteoporosis or osteomalacia. As for example, having an X-ray of the patient, then having this DEXA test. Okay, blood test does not do much, but we can assess the level of this vitamin D
calcium.
and the calcium. Calcium is mostly normal. It's hardly there is some change in the calcium, but vitamin D is very sensitive, and
bone
we can
biopsy,
get
bone biopsy is important.
yeah. What did you say? Sorry.
Bone biopsies.
Yes.
Bone biopsy. Bone biopsy. We hardly do bone biopsy. In my practice, I never do bone biopsy to diagnose a osteoporosis. And funny thing is that even I do not go for this DEXA test as well very frequently because this is expensive. And in our patients, mostly they are so osteoporotic that is readily detectable in X-rays. If you go and see the X-ray of the spine or X-ray of the wrist or X-ray of the hip, you can, you know that is a Singh index. Singh index is very known to these orthopedic surgeons. They can detect the type of osteoporosis from the X-ray of this head and neck of the femur. So this is the test. By this we can detect osteoporosis, and as well osteomalacia can be detected from the tests, but clinically is not detectable. Yes.
I want to request Dr. Shobha Prasad. Do you want to add anything differentiating osteomalacia and osteoporosis?
Now, in these new books are there is a clear cut there is a clear cut statement, sir. There is no evidence of diagnosing osteoporosis in radiology or X-ray, because radiology can only diagnose radiological osteopenia. Sir,
Okay. I want to know from
Actually, in the past, we know there are some radiological indexes by which we could detect. In the past, we used to use that. We used to take the X-ray from the couple, and then used to then we used to try to detect the index.
cortical index.
That is the ratio between the cortex and the medullary cavity. And this nowadays these are not that used because DEXA is available. Other forms of investigation, better investigations are available. So we should go for those things. Okay. Any other question?
Sir, I want to add something.
Yes.
I want to differ with our Honorable Professor Khandekar Abdullah Rizvi. Sir, already Shobha Prasad started saying that. I want to say that one. X-ray, we can detect there is something wrong in the bone. There may be reduced opacity, that is bone density we can see. We cannot see the bone density with X-ray. X-ray is not a diagnostic tool nowadays to detect the osteoporosis. But sir says it is expensive. Probably it is not so expensive. I did this study, and my patient, this is financed by some group, and patient get free investigations. It is not expensive, and I requested that company that you will give the 50% discount package, and they given 50% discount, and we do this study. It is not so expensive, sir. And,
okay. Okay, I do agree with you. That may not be that expensive, but you know this according to your study, you said at least more than 70% of the patients in Bangladesh above the age of 70 are osteoporotic.
42.5%. 42.5%.
And you know this in X-ray, when this more than 30% of this bones mineral has been removed, then it is detected in X-ray. So when X-ray can detect an osteopenia or osteoporosis, then I think there is little value of DEXA. Even then, nowadays modern science detect many things, and we have to go for those things, because money is not very important nowadays. People want to know the diagnosis, and as a clinicians, we should not be miser. I must say, I didn't want to prevent you from doing BMD, but go for BMD and have a good diagnosis and satisfy your patient. That should be the motto of the modern day physicians. Okay.
Any question more?
Yes. So the next question is
Dr. Kasturabhi. Dr.
Yes, sir.
Kasturabhi.
Please, sir.
Can I add something with Professor Rizvi, sir?
Sure, sir. Just
a line.
Yes,
sir, basically the thing is that by the X-rays we can see the deficiency of the bone density, but we cannot diagnose the osteoporosis. We cannot differentiate osteoporosis between
Osteoporosis
and osteomalacia cannot be differentiated by the X-ray.
Yeah, I know. Yes, there is no doubt about that.
Yeah. So the next question, I am going for the next question. The next question is for Dr. Ananthi Ranjan Mondal, sir. Is there any relationship between osteoporosis and calcium intake in diet? Ananthi Ranjan Mondal, sir. Sir, can you please say yes?
Okay. Yes. Good evening. Thanks everybody, and thanks RAS TV and all of you include me in this session. Grateful for this, and especially my very favorite student, Dr. Shuvo. Now the question is the relation between calcium intake and osteoporosis. So already Rizvi sir the formation of bone in osteoporotic bone, not only osteoporotic bone, in developing bone, in maintaining bone, in osteomalacia bone, whatever may be the bone, for the development and for the repair, calcium, vitamin D, and other minerals and the proteins are essential for this repair of bone. So osteoporosis, the bone is already been fragile, and in many parts it is already been fractured. So for repair, we should add vitamin D as well as calcium as supplementary in addition to other treatment, whatever it may be, other drug treatment like bisphosphonate, thyroid hormone, or calcitonin, whatever it may be. But we should add a prerequisite calcium as well as vitamin D and other minerals and proteins also.
Thank you, sir.
So thank you.
Thank you. So the next question is for Professor Syed Shahidul Islam, sir. The question is, sir, can you please say about the rationality of prescribing tablet calcium and tablet cholecalciferol in low back pain, in osteopenia, in osteoporosis?
Probably this question has been answered by two our panelists, by Professor Khandakar Abdullah Rizvi and just now Dr. Anadiranjan Mandal. Yes, there is role of calcium and vitamin D, because calcium and vitamin is needed for bone formation and bone mineralizations. If you don't add calcium and vitamin D, it is not for the treatment of osteoporosis. You want to gain bone mass by giving other drugs, by giving exercise. If you don't add vitamin D and calcium, cholecalciferol, 0.25, the dose, daily dose is normal. So I said, you have 1200 milligram calcium. Normal requirement is 1000. I said 1200. And normally, if we prescribe vitamin D in patients, 400 international unit. But I said for this patient, 800 international unit. It is the more amount should be given. It with drugs plus supplement, total 800. So this is needed for the repair of the bone, for new bone building. It must be added. Though there is no correlation between the development of osteoporosis and vitamin D and calcium. There is debate all over the world regarding these 2 points. But if our people usually buy calcium or come to us or give me some calcium, my bone is weak. So excessive use of calcium may produce some heart disease and renal stone. Remember it. Thank you.
Okay. So the next question is...
I want to add some 1 or 2 points here, because in our country, the patients have peculiar ideas about their drugs, and nowadays it has become a vogue of taking medicines like calcium and vitamins. Okay, and you must be knowing that many of our Bangladeshis living outside the country in Europe and America, very frequently they send big boxes of medicines which is available over the counter. Mostly these are vitamins and calciums. They send it to their relatives. Okay, if it is for this elderly people, it's okay. You can take calcium and vitamin. Whether there is deficiency or not, it is not going to do any harm. But even young people start taking this medicine. When somebody is suffering from back strain or mechanical back pain, even he is willing to or interested to take calcium. This is a misuse of drugs. We should not encourage these unnecessary medications like vitamins and calciums and this kind of medicines which is available over the counter. Okay.
Yes, sir. Yesterday I saw a patient came with a big bottle of 120 calciums and was asking me the expiry date is soon. How should we all can take this one daily? That is the four-person family. They want to finish it by 15 days maybe. Okay, so the next question is to our panel of expert and also to the speakers. Why atypical fractures occur after long-term use of bisphosphonate? Why it is atypical?
Okay, Shubha Prasad is not answering any questions. Are you interested to answer this question, Shubha Prasad?
Shiva, you can unmute yourself if you want to answer this question. The question is why atypical fractures occur after long-term use of bisphosphonate and why it is atypical.
This fracture usually occurs in the proximal part of the femur. Atypical fracture.
That is the
Bisphosphonate, we call it the bisphosphonate structure.
During their follow-up visit.
Definitely. Definitely.
Okay. And what will be that?
Can
is
I
there any guideline? Yeah, sure, sir.
I don't understand the question. Okay.
Sir, pre and post-menopausal women. Is there any comprehensive management for the pre and post-menopausal women? That is peri-menopausal women. Is there any comprehensive management plan to combat this situation? The Kaisur asking this question.
So I'm just asking it for the from the audience. Actually, the audience is
you're
eager to.
Okay, can I answer?
Yes.
Yes, sir.
Definitely there is a. Can I answer or any other can answer?
You are allowed to
Otherwise,
answer
if you
the
are interested,
question.
you can answer.
Sir, it
But
is guided to all
I'm
our
afraid
panelists.
to answer
Anyone can
this
answer
question.
this.
I'm
Okay.
really hesitant to
Anwar sir, you can
answer
answer
this
that.
question. If you are confident, you can answer this question.
Okay.
Sir, you can answer, sir. Please, sir. Sir.
I'm really hesitant to answer this question.
Sir, it's okay, sir. You can start it. And
Developing a comprehensive treatment protocol for osteoporosis is very, very difficult. So simple way of doing this is categorize the treatment protocol, start from simple, then gradually add on the drugs available in the nowadays. Initially, when the patient present to us having no symptom at all, but patient is menopausal, then we know that a menopausal, at least one in 3 menopausal lady will develop osteoporosis. So we can consider them potentially osteoporotic. So we will have to give them treatment like lifestyle modification, okay, diet, and simple drugs like calcium and vitamin D, okay. But if the patient has some postmenopausal symptoms requiring hormone therapy, then we can start with then ACRMS for certain time, for 5 to 10 years time. Then alendronate is a good drug. If a patient can orally take alendronate, bisphosphonate, not alendronate, newer bisphosphonates, then it is better to continue orally. But if has difficulty in taking drug orally, then injectable forms of drugs are available. There are many drugs available depending on the patient's economic condition and patient's condition and the stage of osteoporosis. Then we can use better drugs, anabolic drugs like teriparatide or like that. But we must understand one thing. We have so many drugs available in the market, but if the patient is osteoporotic, we can slow down the osteoporosis. It is very difficult. I'm not sure. I have not seen any patient. I could not revert any patient from osteoporosis to normal. Even in my patient, in my series of patients I have treated, I could not even increase the BMD a little. If the patient is presented with say minus 2.5 standard deviation of osteoporosis T squared, okay, even after treatment we could not revert to minus 1.5 or what. I have not seen any patient has done this kind of change. So is that it is very difficult to revert the osteoporosis. What we can do, we can slow down the process. And best thing is that not the drugs, is the physical activities and the lifestyle modification. As for example, Shohid has Professor Shohid has nicely mentioned that leaving the smoking, leaving alcohol, then other bad habits, and if you are taking some drugs, then it is really difficult. If you have rheumatoid arthritis, you are taking steroid, then for you it is very difficult situation to manage this kind of osteoporosis. But I would like to advise this way. Okay, change the lifestyle. Okay, improve your diets. Okay, go on taking certain drugs. Okay, relatively harmful drugs. Then start with calcium, vitamin D. Then gradually
do you want to add anything with adject to this thing? Then I'll go to
Definitely,
Professor Dr. Shahidul Islam.
Sorry, definitely, Professor.
It's okay.
Definitely, Professor Khundukar Abdul Rizvi sir says rightly, the lifestyle modification and the exercise and activity and the definitely discourage some bad habits, that is alcohol taking, cigarette smoking, and the caffeine taking and other things that should be stopped. Definitely, and some drugs as well. But I am not agree totally with the sir that BMD is not been improved by treating the osteoporosis. Even properly treating the osteoporosis along with some calciums and vitamins, the process can be halted, process can be slowed.
যে বোন এলিভেশন যেটা করা যায় যে বাইরে থেকে ইনজেকশন দিয়ে, আমাদের এখানে কি আমরা কেউ করছি কিনা?
জি স্যার।
স্যার আমি করি স্যার। স্যার আমি করি
কাইপোপ্লাস্টি।
হ্যাঁ,
বেলুন কাইপোপ্লাস্টি করি স্যার এবং ভার্টিব্লোপ্লাস্টিও করি।
ভার্টিব্লোপ্লাস্টি, কাইপোপ্লাস্টি এটা করা হয় স্যার। তারপরে আমাদের তো ফিক্সেশন আছে।
না ফিক্সেশন আমি কাইপোপ্লাস্টি কথা বলছি।
Last question.
So last question to Professor Said.
বঙ্গবন্ধু ইউনিভার্সিটিতে হয় স্যার।
Please.
Kaisar Rabi. Professor Rohak sir want to know where this procedure is done in Bangabandhu Medical University.
Apart from the institutions, in some of these private clinics, this has been practiced, vertebroplasty and kyphoplasty. Okay.
Sir, two of my students also doing finished his thesis on kyphoplasty, sir. Their thesis was in MS in kyphoplasty, balloon kyphoplasty, and I was the guide, sir.
I want to add one minute what the Professor Khandekar Abdullah is saying. We in our study we have added ebandonic acid and follow up. We have given ebandonic acid and we have follow up for 1 year only. So we are not telling about this. By this time, 1 year, ebandonic acid, some patients show some increase in BMD, some patient, very low percentage, and some remain steady. And some of the patient below the previous level. So we'll get this result after 5 years. We will evaluate the result after 5 years. And one thing we have to say that after 5 years of oral bisphosphonate and 3 years of intravenous bisphosphonate, we have to give the bisphosphonate holiday. We have to stop this bisphosphonate. And we have to follow up this patient for another 4 or 5 years. And if necessary, we can do BMD not before 2 years. After 2 to 4 years, we have to evaluate by doing BMD. If we find that BMD is lowering again, then we can add. We have to give up to 5 years bisphosphonate. This is known as bisphosphonate holiday.
Okay, so actually, so the problem is, this is being studied in the Western countries as well. Okay, to see the efficacy of the drugs, but it is really frustrating that even after so many drugs and so many, only the teriparatide, which is anabolic agent. Okay, only teriparatide is anabolic agent, and which can show some improvement in the bone quality. apart from
Sir,
other
we have some experiments.
I-
It is not statistically we cannot show. Patient comes with us with low back pain, a man having osteoporosis, but after giving injection Jolindol acid, patient pain disappears. Patient is getting well.
that is another issue. So it pain goes for
This
very
is a subjective issue. Subjective issue.
but if
We cannot say
that
statistically.
bone quality has improved,
See,
then you will have to have your bone biopsy to definitely say the bone
Sir,
quality has
can I
improved.
intervene?
Okay, this
Yes.
is not very easy. So we need to have our really good scientific studies to say about this improvement in the bone quality. I hope the people, the scientists like you who are working hard, okay, in future we will get some result. Okay, but
Sir, may I intervene?
sure.
So now
Sure.
time becomes the concern for us. We need to
Okay,
conclude
okay.
this session,
But,
and maybe we'll continue
I
this.
would like to put a
questions
comment
again.
actually. I would like to put a comment actually because osteoporosis is a serious problem even in Bangladesh. We know that
Yes.
because with the orthopedic surgeons we get a lot of fractures, osteoporotic fractures, and Shuit has also mentioned that following a hip surgery, following osteoporotic fractures, there is 10% chance of dying within a year. And Shohid also mentioned that 50% patients who have had hip fractures will not have a normal life after surgery. 50% and 10%. It is huge number. So this is a serious problem, and it is estimated that it is projected that in 2050 the number of hip fractures in the world will be 6 point something millions. Okay, it is a huge number. So this
Yes,
is
sir.
a serious problem, and so far we understand that the treating osteoporosis is very difficult. Anwar has mentioned that he has many option time where you can have the maximum what do you call it amount of bone mass in our body. So this is the asset, this is the bank balance. If somebody can have a healthy bank balance, then he can have a
Yes,
very
sir.
and rest of the life.
I compare usually with
Go
this.
for the-
That
go
you
for
should
the
have that bank
prevention.
balance.
Now,
Oh.
can I? Okay. So
Chairperson.
now I'll humbly request former Ruhul Haq, sir,
Yes.
MP, to conclude this session and give his closing speech. Please,
Yes,
sir,
thank
if you
you.
can.
Anyway, thank you very much. Thank you, everybody. Sir.
Thank you, Ami. Thank you, everybody, for a beautiful session. Sorry, I missed a little bit in the beginning. This is a long, drawn-out process which has not been solved. What Professor Rizvi was just saying, that there are a lot of things we do not know as yet, and there is quite often a lot of pain in the back. Often we say it is osteoporosis. Often we say osteopenia. The drugs that are given that often helps, but as rightly mentioned, that if you want to prove something, you have to do the biopsy and analysis. While I was raising my hand, this is the only point I would like to make. You see, we have nice institutions now, especially our NITOR, beloved NITOR, what we love. Now we have to transform NITOR from only clinical treating institution to a more research-oriented institution and do not only some thesis and for the boys, but post thesis, post doctorate, post fellowship, post-MS, some kind of things we should have. The things that you are mentioning, I don't know whether you're doing some kind of research plan and research program, not only into this, but also bone cancer, other problems, pediatric problems, so many other things. And what I am trying to impress that NITOR should have a very good research, proper with capital letter P and proper research team, not just showing research team. So I think it is about time. You have got a new building, you have got new institutions, you've got a lot of people, lot of students. One has to, there are money in the research arena in the health institutions. So one should try to do something. Not only we say that the biggest hospital giving nothing to the World Orthopedic Society, we cannot prove anything. So that is not a good thing. So তোমরা যারা আছো ইনস্টিটিউশনে আমি তোমাদেরকে বলবো please do try to have this side very strong research oriented side. And kyphoplasty, I don't know why you in it or if people are not starting. This has been a long way. A lot of people are doing it in India, Singapore, America. The first thing I saw it in America. That's never lived more than 20 years ago. So we have still, I think it's a very good surgical procedure. Somebody in NITOR should also come up. I'm thankful to Dr. Anwar that you people are doing it. I miss a lot of things about this, but nice to hear from you all. And nice talking to Professor Rizvi and everybody, Shahidul and all others. Good presentations from the young Rashid Prashad. Thank you very much. And some of the other, they also, somebody presented very nice paper. I enjoy this young company and love to see you that you people are doing it more and more. Some basic research protocols in DSMMU and NITOR and places like that should really come up so that we can show that we are coming up with orthopedics. So we can think of what are the projects somebody is taking, and then we can really prove ourselves. Our students, our teachers, seniors, we are no less than anybody else in the world. We need some technical guidance and a department to establish the research side, like an office, with some people to do this problem. Thank you all. Thank you very much for having me. Wish you all the best. And COVID is creating a problem. I think we have lost 2 orthopedic surgeons or 3. How many we have lost?
So far, 50 doctors. We have lost 50 doctors.
No, orthopedic surgeon. Orthopedics. Orthopedics only Musharraf Hossain says.
Only one. I see. So
yes.
We definitely pray for his soul, and we pray for all the souls of the doctors that have lost. I have put in my Facebook about something for these young doctors or doctors being affected by the coronavirus. Those people who are listening outside the view, my feeling, especially for the seniors who are especially working in the hospitals, my feeling is that it is very clear. There are only 2 ways that the virus can enter your body. Either you are not wearing the PPE or protective gear, whatever you have, or you are not protecting it properly. So I have my feeling that I get very emotional when I see that somebody is losing life. A young doctor losing life is a very, very sad thing for me. That the doctor, the family, the children, the wife, the mother and father is still there, and somebody is going away. You see, a lot of people are working into the corona unit in the ICU, not only here, but all around the world. Everywhere I speak, I have spoken to China. I'm speaking to Chinese doctors tomorrow. I've spoken to India, I've spoken to American doctors who are working in the corona unit inside the ICU. They said we do not get affected, or most of us are safe. Whereas we have lost 33, 34 doctors. So this shows that there must be deficiency somewhere. Either the protective gear is not okay, or the wearing and the turning and dropping the mechanism we are not following. I would like to request you people, the seniors, most of them are seniors here, to see your juniors, whoever it is, the health workers, maybe doctor, the nurse, the assistants, whatever it is, that they have, they are learning it, they are following the exact way of proper way of wearing it and taking it off. I think I have said that I do not really like something like wearing and learning how to wear and take it off always online, because most of our doctors do not pay attention. I like to do it really on face. Like if it is a knittor, like to get the training, real training, not online, but on the face, that this is how you have to do. It's not wearing the, as you understand, পরার সময়টা problem to না. Actually problem to taking it off and doing it. And then what you are doing, how you are protecting yourself.
Okay.
This has to be taught. In an institution like NITOR, you should have a training all day, every day, every week, everything, and review how the people are doing. Like in other institutions, Bangabandhu and other medical places, I think you should take it very seriously. Otherwise, we are going to lose some more lives, and hopefully we can prevent that. So thank you very much. Thank you. Wish you all luck. Best wishes to everybody. Thank you. Thank you.
Thank you very much, sir. And thank you very much to our two very good speakers. They have presented very nice presentation, and thanks to our.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.
See you all in the next time. Thank you all. Take care.